Welcome to the Berggruen Forum. Thank you for coming. One announcement is that next week we have Ted Forsyth, a graduate of Alfred University, philosophy, no less, and currently adjuncting lecturing in social justice. And he is giving a talk on the power of the FOIL, that is the Freedom of Information Law, using it as a research tool. Ted is very active in social justice issues in Rochester. And so that's next Thursday after the break. Berggruen Forum has a proud tradition of being very topical and up to date, and never more so than today. We're very happy to have Meredith Field, Professor of Sociology. She is going to talk about abortion, whose opinion matters. Thank you.
Okay, hello everybody. So the title of my talk, as Emrys mentioned, is Abortion, Whose Opinion Matters. And that's actually what I'm going to leave you with at the end. So what I'm going to spend most of my time doing today is talking about what I mean when I say abortion. I'm going to talk about the sociopolitical kind of historical context of abortion in the United States a little bit. Then I'm going to talk about what abortion access looks like in the United States today, but not necessarily today because it's changing almost daily. And then I'm going to talk a little bit about how the current abortion policies affect access to healthcare more broadly. And then the last thing is whose opinion matters when we're thinking about abortion and talking about abortion, okay? But that's really what I'm going to leave you to think about and hopefully discuss. Okay, so what is abortion? And I want to kind of take a broader view and talk first about what birth control is. In the US, when people say birth control, they're often referring to hormonal contraceptives. But reproductive health scholars and other people in the reproductive health field talk about birth control as anything that controls when and how many pregnancies occur in a person's life. And that can include abstinence, eugenics, contraceptives, abortion, and other means. And then within that umbrella of birth control, we've got these two big areas, contraception and abortifacient. And contraception is the deliberate prevention of conception or implantation. Examples, we have different barrier methods, hormonal methods, chemical methods, and natural methods. And then we have the abortifacients, which I'm going to focus on today. Any substance or practice that ends a pregnancy. In the US, we have medication abortion, dilation and evacuation, suction abortion, and some people use herbs and oils and other substances. So when I talk about abortion, generally, I'm talking about pregnancy termination, and that includes both induced through medical, chemical, or manual means, and spontaneous abortion, which we commonly refer to as miscarriage. These are three common plants: American pennyroyal, tansy is the yellow, and then you also might recognize Queen Anne's lace, the white flower, that have been used throughout history to terminate pregnancy because of different properties in those plants. To break it down into a little bit more detail, we've got different abortifacient substances, medication, which again, commonly referred to as the abortion pill, which can be used up to 11 weeks post last menstrual period. So this can be used up to 9 weeks of gestation. There are people in the US who use other types of chemicals to terminate a pregnancy. Then the medical community also uses medically induced abortion procedures, typically surgical, and two common ones, suction, which can be used up to 14 to 16 weeks of gestation, and dilation and evacuation, 16 to 22 weeks. Again, keeping the idea that miscarriage is also considered to be a form of abortion. It's a spontaneous abortion, and it's estimated that about 1/4 of all pregnancies end in miscarriage. I wanted to talk really briefly about the medication abortion pills, because I think the abortion pill is something that's kind of thrown around, but we don't necessarily know what that means. It's actually two pills taken in sequence. And the first one is mifepristone, brand name Mifeprex, which blocks the production of progesterone. A pregnancy cannot continue without the pregnant body continuously producing progesterone to support that pregnancy. So taking the mifepristone first stops the pregnancy, and then taking the misoprostol or Cytotec, which is the brand name, will actually cause the uterus to contract and expel the contents of the pregnancy. Cytotec, just some kind of interesting knowledge about it, was originally approved by the FDA to prevent and treat stomach ulcers caused by taking NSAIDs or anti-inflammatory medications. And since then, it's been used for decades also to induce childbirth, to induce labor. That's an off-label usage that the FDA has actually spoken against, because when it's used to induce labor, it can sometimes cause the uterus to rupture and it can kill the person who is in labor. But now it is used safely in combination with the mifepristone to terminate a pregnancy. Okay, so a little about the sociopolitical history of abortion in the US. For a long time, abortion was practiced in North America by indigenous tribes. It was practiced throughout the 13 colonies and in the first century of US history. It was done safely until quickening. Quickening is a really important term. Quickening basically means that the pregnant person can feel the fetus move. And that can happen anywhere from 14 to 21 weeks. So it was generally considered to be acceptable for much of our history before quickening, before the fetus could be felt to move. And it was handled by women and midwives. Up until the 19th century, there were no federal or state laws criminalizing it. And in fact, in 1812, in Massachusetts, their Supreme Court decision in Commonwealth versus Bangs held that abortion with a woman's consent and before quickening was not punishable at common law. And generally in the US at that time, the institution of medicine, the discipline of medicine was just really getting off the ground and developing. And so in some of the very first medical texts, here's an example of one right here, domestic medicine. There were many references to abortion as ways to treat obstructed menses. So the issue was somebody stopped having their period, we can fix it, take this substance or do this thing, and you will get your period back. But essentially it was abortion that was happening. During the 19th century, and again, I'm just highlighting key points. I'm going through US history really quickly and just picking up things that I think are important for this discussion. The US birth rate started to decline rapidly, and abortion was becoming more common as the medical field was developing ways that they would do abortion. And in 1847, the American Medical Association was established to legitimize medicine as an institution, to legitimize physicians. And the AMA also wanted to make sure that it stifled any competition. So before we had medicine and physicians, we had midwives, we had other forms of healers, and the trained doctors, which of course were nothing like the doctors we know and trust today, they wanted to eliminate the competition. So they took over as many of the different kinds of practices and got as much of the knowledge as they could from the other types of healthcare providers. In 1821 is when we saw the first anti-abortion law, and it was passed in Connecticut. This came out of a scandal between an Episcopalian minister and a young woman who he had an affair with. She became pregnant and he wanted her to end the pregnancy. So he made her get an abortion. And so this first law was criminalizing the person who provides abortion. It wasn't criminalizing the person who has an abortion. It was criminalizing the provider of abortion. And it was also still focusing on quickening as a limit or as a line, right? So before quickening, it was still going to be acceptable to have abortion, but after quickening, it would become a serious problem. After that time, within about the next 90 years, abortion progressively became illegal. State by state, there were more laws passed to criminalize it. And in 1857, Dr. Horatio Storer actually led a push for the AMA to campaign to make abortion illegal throughout the US for moral reasons. So this is when we first start to hear and read about the morality issues around abortion. According to historian Leslie Reagan, 1869 is when abortion first really becomes politicized through these organized campaigns to criminalize it and through the morality issues. And it's also when we have the first signs that the Catholic Church is going to be condemning it. Okay, that's when that starts. By 1910, most states had criminalized abortion through legislation, and the Kentucky courts had deemed it illegal there. So generally speaking, from that point forward, abortion was illegal in the United States until Roe v. Wade in 1973. So this infographic, I don't know if you can read it, I'm going to talk through it a little bit, kind of summarizes key points from the Roe v. Wade decision. And that decision said that in the early stages of pregnancy, because a fetus can't survive outside the womb, the pregnant person's rights to terminate the pregnancy outweigh the state's interests. But at some point, the fetus can survive outside the womb. And here, the concept of quickening is replaced with the concept of viability. In 1973, based on our scientific knowledge, viability was considered to be between 24 and 28 weeks. And so the court said, after that, it's in the state's interest to decide if they want to allow people to abort pregnancies. So during Roe v. Wade's reign, even though abortion was legal, there were many states that were working to erode abortion access rights. And the federal government even passed the Hyde Amendment in 1976, which said basically that no federal funds could be used for abortion. In 1982, my home state of Pennsylvania passed the Abortion Control Act, which is one of these first big erosion laws. It required parental consent for any minors who were seeking abortion, 24-hour waiting periods for anybody seeking abortion, spousal consent for married women seeking abortion, counseling with state mandated content before abortion, and extensive provider reporting. So this is when abortion starts to be treated administratively different than other healthcare procedures. And in 1992, there was an important case, Planned Parenthood versus Casey, which upheld everything in the PACA Act except for the spousal notification requirement. Further erosion was happening in the 21st century. In the early 2000s, trap laws are something that were talked about a lot. You might have heard this, the targeted regulation of abortion providers. And examples of this include things like requiring physicians to have admitting privileges at a hospital within a certain radius, and applying a state's ambulatory surgical center laws regarding minimum room size or hallway width to a clinic where maybe only medication abortion was administered. Other things that were happening to kind of bring into question the legality of abortion and what kinds of laws could define who can get abortion, when, how, why. The issue of viability, the concept of viability, which viability is not a scientific or medical term that has a clearly defined time or area or way of determining when a fetus is viable. So there were a lot of legal challenges to the concept of viability and to Roe v. Wade saying that it was between 24 and 28 weeks. People were saying, look, our medical technology, our medical science has improved. So really, for many fetuses, if they are born before 24 weeks, they could be viable, they could survive. So we need to consider changing this. And then we also have this type of law called the heartbeat laws. It's known to kind of common people, which is a ban on abortion at 6 weeks of gestation with the belief that there is a heartbeat at 6 weeks. But doctors and scientists say that actually the heart doesn't develop in the fetus until 17 to 20 weeks, so there can't be a heartbeat. There are electrical pulses that can be detected by ultrasound, but there's no heart until much later, so there isn't actually a heartbeat until that time. So as all of these laws were being passed at the state level to erode access to abortion, and as the makeup of the Supreme Court was changing and it was becoming more conservative, many states were preparing for Roe v. Wade to be overturned by creating trigger laws, saying that when Roe v. Wade is overturned, we will immediately outlaw abortion in our state. And this Guttmacher Institute map shows, this was as of 2021, I think it was last summer, that there were 26 states that were certain or likely to ban abortion when Roe v. Wade was overturned, which of course happened this year, this summer. The Dobbs v. Jackson case, which asked whether Mississippi could outlaw abortion at 15 weeks of pregnancy, which is before viability. Again, that issue of viability coming up. So on June 24th, the decision came down, it overturned Roe v. Wade. Justice Alito wrote the majority opinion. And one quote that I pulled out from that opinion says, procuring an abortion is not a fundamental constitutional right because such a right has no basis in the Constitution's text or in our nation's history. Legal scholars have been pretty critical of the opinion that Alito wrote, saying that for one thing, he relied a lot on liberal judges. He cited liberal judges, but he took them out of context. And that he also cherry-picked the data and ignored precedents and aspects of history that contradicted his opinion rather than responding to them as part of his opinion, which is common. Here's an example from a professor of law at Cornell University, Michael Dorff, who says, Justice Alito's other citations are even more dubious. His reliance on scholars who criticized Roe but believed it should remain the law was at best incomplete. So again, just a little bit of the context of abortion and how people have been thinking about it and talking about it and dealing with it policy-wise and law-wise in the US. So what's the current state? Like I said, it's changing regularly. This is a map from last week, so it might not be accurate anymore. And it's showing what the legal status of abortion is in various states. So if you look at the red states, these are states where abortion is completely banned. There are 14 states. The purple states, abortion's banned. The abortion ban is temporarily blocked. So as you might be aware, or you could imagine, in many states around the US, there are legal challenges to abortion bans, to abortion access. There are all kinds of legal challenges at play, and there are changes. That's why there are changes almost daily. The light blue, abortion is available. There's a pre-viability gestational limit in effect. That's 7 states. And then the one state that is like a gold color is a 6-week last menstrual period gestational limit in effect. And then abortion is available in 24 states and DC. And I think that even looking at this map, it's a little bit misleading as to the real status of abortion in some of the states. For example, my work is in Ohio. I'm going to talk more about that in a minute. And Ohio is here noted as abortion available, pre-viability gestational limit in effect. But in reality, if there weren't challenges to its laws, it would actually have abortion banned at 6 weeks. So they're trying to get there, but right now they can't because of the legal challenges. So when are abortions happening? Most abortions happening in the US these days are happening before 10 weeks of gestation. And they're pretty expensive. Last year, the median cost of abortion services exceeded $500. And you can see the green bars, the top bars are the medication abortion. So just to get those 2 pills, on average, it was over $500 to get that. But when we're talking about abortion in the news, in conversation with our friends and family, we're typically talking about and thinking about abortions that people are seeking because they don't want to continue their pregnancy. We're typically talking about physicians who provide abortion as some of their primary work. And we're typically thinking about clinics that provide abortion as one of their main healthcare offerings. But there are other abortions that are happening in the US. They're less talked about. It's a small portion of abortions in the US, but they're also really important things that are happening. So I'm going to talk a little bit about some research from my postdoctoral fellowship. And that, again, that happened in Ohio. And it gives us a way to think about kind of a more diverse set of abortions that occur in the US. So Ohio is a place that was working really hard to erode access to abortion before the Dobbs v. Jackson decision. Between 2010 and 2019, they enacted 16 different restrictions. And so abortion is still legal in Ohio, but it's very complicated as to who can get access, when, how, and what physicians are allowed to do and what they have to do in terms of reporting. Because, as I said, most people, most media outlets focus on abortion clinics and people seeking to end pregnancies because they don't want to have a baby. Our research said, how do these abortion regulations affect the reproductive healthcare practices of clinic adjacent OBGYNs? So the people who aren't working in abortion clinics, they're working in hospitals, maybe in private practice, And they're primarily working with people who want to take their pregnancies to the end. They want to carry them full term and have a baby, right? My work was part of the Ohio Policy Evaluation Network, and that's a research collaborative that involves scholars from University of Cincinnati, Case Western Reserve, Cincinnati Children's, and the Ohio State University. For our project, we engaged in interviews and focus groups in 2019 and 2020. We recruited OBGYNs who had practiced outside abortion clinics, mostly in hospitals within the previous 10 years. We had 35 participants, and mostly they discussed how the increasing abortion restrictions in Ohio complicated their practice when they were attending to these patients attempting to carry pregnancies to term. Our three key findings were that abortion regulations framed abortion and physicians who provide it as separate and distinct from other types of medical practices and other physicians. Two, that many institutional interpretations, and when I say institutional interpretations, I'm talking about mostly hospitals as the institutions and how they interpret the regulations, was undermining physician expertise and their professional autonomy. And this last one, which I have highlighted because it's the most important for this talk today, is that the constellation of abortion regulations, institutional interpretations, physicians' trepidation about whether or not they were following the laws correctly and what the consequences would be, and their perceived inability to exercise clinical judgment work together to limit abortion access and increase risks to patients' lives and health. So that's a mouthful, and that's kind of abstract. So I want to give you a more concrete example, and I want to take two pieces of Ohio code, the Viability Ban, as it's commonly referred to, and then the 21.6 limit. The Viability Ban bans abortion once viability is confirmed and requires viability testing at the 20th week of pregnancy post-fertilization. There are medical emergency exceptions, but not for mental health. So again, here's this concept of viability that isn't clear-cut. It's something that if you are pregnant and your physician has to determine whether your fetus is viable, whether it could survive outside of your body, they're going to take ultrasounds and try to look at how the organs have developed, like what is the status of the fetus? Does it seem ready? Does it seem healthy? Is it baked enough, right? Basically, we say to come out and be able to survive. Maybe take measurements, look at the overall health of the person who's pregnant. So it's kind of complicated to actually establish viability, and it's not a perfect science. Then the other one, the 21.6 limit, established the legal limit for abortion in Ohio of 21 weeks and 6 days gestation after last menstrual period. So we've got these two pieces of code that our participants talked about a lot. And they said, you know, these laws, the second one, not so much, but the first law is really vague because of this concept of viability and what viability testing looks like. Because of that, it's making us fear both criminal and civil liabilities, and it's making our institutions fear those liabilities. So our institutions are responding in different ways, some being more conservative about when it's okay to make an exception and offer an abortion, and some being more liberal about it. And it's making it hard for physicians to exercise clinical judgment and follow the ethical guidelines that they were trained in when they went to medical school. One kind of medical situation that they talked about a lot is the case of PPROM, and this is preterm premature rupture of membrane. So this is going to get a little bit technical, but I'm going to try very hard to break it down as much as I can. This is basically, you know, during pregnancy, there is a sac of fluids that the fetus develops inside of. And that sac of fluids is not supposed to break until the fetus is fully ready to be born as a fully developed baby. But sometimes the waters break early, and that's the premature rupture of membranes. And when it happens before 37 weeks of pregnancy, it's considered to be preterm, before the fetus is fully ready. And it creates a risk of infection that can lead to organ damage for the pregnant person and or death. There's also extreme PPROM that happens. That's considered anytime there's PROM before 26 weeks of gestation. So the earlier in the pregnancy that this happens, the higher the risk for the pregnant person and the lower the chances of survival for the fetus. So when this happens early on in the gestation, when the fetus is not considered to be viable, and this is typically For most of our participants, they said it's before 24 weeks. Participants in all of our focus groups and our 2 interviews said that they would consider offering pregnancy termination to protect the patient's health and life. But because of the 21.6 limit in Ohio, they can't. So instead, they have to sit by and watch and hope that their patients don't develop any sort of infection that will risk organ failure or death. But sometimes that happens. And when it does, the physicians are not able to just determine, okay, this person's life is actually at risk now. I'm going to offer them an abortion. If they want to take it, it's up to them. Instead, they have to go to their hospital's legal counsels who say, we don't know. Are they really about to die? Because if not, we need to wait till they get closer. We don't want to take the risk of being sued or having the state come after us. And so this was really disturbing for the physicians who were in our research study. And 2 illustrative quotes from our participants. One said, the patient has no interest in finding the natural course of a deadly illness. That's not something that you want to see when you have an intervention that you can do. You feel very backed into a corner. And another participant said, it feels like an experiment, like legal counsel are just sick people experimenting on women. Her water's broken, the baby's not going to live. It's like giving people syphilis and seeing what happens to them. It's really, really barbaric to me. So the participants in the study were usually visibly upset when they were talking about these kinds of examples. And I think one of the hardest things for them was that their patients are people who wanted babies. They wanted these pregnancies to go full term. And suddenly they find themselves in situations where they have to make these really difficult kinds of decisions, but the doctors aren't able to just have conversations with their patients the way they want to and be empathetic and talk them through these hard decisions. Instead, they have to worry about a lot of legal restrictions and hoops that they have to jump through and getting approval from their lawyers. Okay, hopefully you followed all that. I'm sorry that it was a little bit medically technical, but I have faith that you did follow. So, okay, so how do current abortion policies affect access to healthcare beyond abortion? You've probably seen headlines about some of these issues. Non-pregnant women and girls are being denied life-saving medications due to fear of abortion laws. One 14-year-old in Arizona who has serious arthritis was denied her medication because of the abortion ban, because there was a chance that if she was pregnant, it could terminate the pregnancy if she took her arthritis medication. She wasn't actually pregnant, but the pharmacy that she typically went to decided they didn't want to risk that she might be. So people, girls and women, not able to get medications that they need. There was a story about somebody who couldn't get their cancer drug because cancer drugs can cause pregnancy termination sometimes as a side effect. And again, these aren't people who are necessarily pregnant. It's just concern that they could be. And so physicians are not prescribing some medications and pharmacists are sometimes not willing to dispense medications. A UCSF study also is concerned about people with MS, migraine, epilepsy, not getting their medication. So it's something that healthcare providers and scientists are talking about, worried about, and we're hearing cases come out already. Here's another one. This is not somebody who was trying to get their medication, but they actually had their pregnancy terminate on its own, right? But it was still in the body. They hadn't expelled the contents of their pregnancy. So because of the Texas law, when this person went to the doctor and they did an ultrasound and they said there's no heartbeat, the pregnancy has stopped developing. She said, oh, great, not great, but like now that I know that, can I take the next step and get a D&C, get my uterus emptied of the contents of that pregnancy? And they said, no, we actually need you to confirm again that there's no heartbeat. So she went for a second ultrasound and again had to have the ultrasound tech tell her there's no heartbeat, this pregnancy has ended, which she says was very traumatic for her. And even after 2, nobody would perform the D&C in her area. So she had to get a third one, a third confirmation. And it took 2 weeks to go through this whole process that she knew that she was carrying, a dead fetus that she really wanted to be able to carry full term and have a child. So it was pretty traumatic for her. Okay, so lots of information. And ultimately, the question that I want you to think about and hopefully talk about at some point, whether it's here or somewhere else, is whose opinion about abortion matters. We probably all have our own opinions about abortion. The Supreme Court of the United States has given us their official opinion about it in full, complex written document. And we've got medical opinion. The American College of Obstetricians and Gynecologists, the preeminent body of OBGYNs, considers it to be an important part of comprehensive reproductive health care. They've made statements about that and the fact that when people can't access abortion, it increases other forms of inequality in our country. It puts people who already have health problems at greater risk. And people of color, people living in rural areas, and people with low financial resources are the people who feel it the most. Public opinion. There are lots of polls that are checking on public opinion about abortion, and public opinion in the US has been somewhat stable over a long period of time, but these are just some polls from this summer that show that about ranging from what, 31% to 42% of people polled approved of the Supreme Court overturning Roe v. Wade, higher percentages disapproved. And so there were a lot of different polls that were, somewhat similar, you can see. Over many decades, public opinion hasn't changed too much. And in general, public opinion is that abortion should be available to people, but there should be some limitations on it, right? It shouldn't just be totally available all the time to anyone at any stage of pregnancy. There should be some limitations. But other than that, whose opinion matters? Who gets to decide, and what does it mean for our democratic republic and how we shape laws or not through our democratic process? So we've got the Supreme Court that said the Constitution doesn't guarantee your right to it. So we're overturning Roe v. Wade. We're going to leave it up to the states. Now we have many states who are outlawing it. And even within many of those states, the voters are upset. So the voters are saying, we're going to turn out in record numbers and try to get this changed in our state. But I also don't know that it's a good idea to do single issue voting, to just vote for a candidate because of one issue. So I think it's pretty complicated. I'm not a political scientist. I know there are some in the room, so I'm interested to hear their perspectives on this too. But anyway, so that's what I want to leave you with. Lots of information. I welcome your questions. And yeah, please let me know.
Thank you, Meredith. We have a microphone here. Questions, comments? I'll start off. What's your view of the issue of parental consent being required for minors?
I honestly do not have a personal view on it. One of the things that I like about doing abortion research is that I can just engage with the issue intellectually and not have to think too hard about my personal opinions around it. I have a broad opinion about abortion and it being accessible, but I don't really think too deeply about the specific laws at that level, to be honest.
Are there any laws that protect children who weren't aborted and ensure that they have good lives?
So children who were the result of an unwanted or unplanned pregnancy, they're born, and then are you assuming that they stay with the birth parent?
Either.
I mean, I don't know of any laws that specifically are made with children of unwanted pregnancies in mind. I think we just have, more generally laws that protect children from neglect, from abuse. I'm not aware of any laws like that.
given the discrimination that's happening against women in terms of their medications that they may need for an underlying condition, even Crohn's disease uses some of those medical abortions medications sometimes as treatment. And given the fact that lawyers are more worried about a lawsuit given an abortion than the greater risk they're putting on women's lives when they're in a dangerous medical situation. Are you aware of lawsuits, maybe even class action that are, coming up in reaction to these kinds of situations?
Yeah, I've read about some lawsuits. I couldn't name any specific ones off the top of my head, but in articles about the constantly changing context, there are references to people who are suing. And I think it's kind of an exciting legal landscape right now because there's so many unknowns, there's so many questions. There's a major healthcare law firm in Los Angeles that is hosting, I think they're like monthly webinars that are targeting physicians to try and talk through the various legal issues of figuring out if you are a provider who works in a state where abortion is legal, for example, and somebody comes from another state where it's illegal, could you be held responsible criminally and charged even though you're not in the state where it's illegal? Like there are all kinds of questions like that. And nobody knows the answers. So yes, the answer is yes, there are cases and there are lots of questions and there are more unknowns than knowns. And I think also because the laws are changing so often right now because of all the legal challenges to the state level laws, that it's making it even harder to get close to answers. So.
Meredith, there might be a question in the chat. Can you see it?
I don't see it.
I know, hello? Okay, I know that in New York, we have access to safe abortions, but I was wondering what can we do as like citizens for people in other states that don't have access to abortion?
So the question is, in New York State, abortion is legal, and if you can get to a place that offers it, then you can get access to abortion. But is there something that people who want to see full abortion access for everyone in the US, is there something we can do to support people in states that don't have access? And there are lots of organizations that are working on figuring out ways to provide housing, provide transportation, to help people in states that don't have access get to states that do have access. So probably the easiest thing is to find those organizations like Planned Parenthood and donate to them and their work. There are lots of different kinds of abortion funds that it's interesting how they have been kind of reorganizing. Roe v. Wade being overturned was not a surprise for anybody who works in reproductive health and reproductive justice. It was just kind of a matter of time until it was going to happen. And so there's been a lot of preparatory organizing happening for the last few years. So there are organizations and things that you can do. You just have to look for them. Yeah. There is one question in the chat from Gary Ostrauer. Meredith, my recollection is that historian James Moore argues that much of mid-19th century opposition to abortion was based on the protection of the woman, not the fetus. He argues that about 20% of all abortion and the danger to their lives, infection, et cetera, mandated restrictions. Might you comment on this? Yeah, so one of the slides that I had in here originally, but I took out for time, was some of the different justifications given besides the moral justification for banning abortion. And yes, the idea that abortions were leading to women dying because abortions weren't being done safely. This is one of the justifications that was given. And it was complicated because I think for a long time, using plants and herbs for abortion was the primary way that it was done. But once manual forms of abortion started happening by inserting things into the uterus to end the pregnancy, that was when this issue of infection really arose. And of course, in the 19th century, we still didn't have really hygienic medical practices, right? Because medical practices were being developed. We didn't have painkillers that we have now. We didn't have any of the benefits of modern medicine the way it exists today. And so, yes, that was one of the things cited as a reason to outlaw abortion. Yeah, I don't know if that answers your question, Gary.
I have partly a comment, partly a question. Fascinating presentation, by the way, and thanks so much. I myself come out of like a deeply conservative religious background that I have almost entirely rejected. At one point, I actually went to Albany to like lobby against abortion. That's how much I've changed. Now I'm entirely on the other side. And for me, watching just the travesty of the Brett Kavanaugh confirmation sort of ended any kind of sense that. But anyway, my reaction to this is I'm so interested in the whole background of this. To me, I feel like there should be like this sort of collective horrified response to how we got here politically. And so even whether, however you feel about the issue of abortion, and I feel as if women should have unfettered access to abortion, but like to have like two like deeply flawed presidential elections that transformed our courts, and then just like blatant cheating by Mitch McConnell, so that now we find ourselves with this highly politicized court, and people, conservatives who claim to sort of want a limited government, are accepting having the government right in the room with families, with doctors and patients and women, and accepting like a complete, dismissal of our sort of constitutional process and of our respect for the legitimacy of the Supreme Court. I feel like they have so completely compromised themselves. And what I wonder is if you have like delved into this, is there any sense in which, both people who, the majority of Americans who favor some kind of access to abortion, with those who reject this, like completely overstepping and allowing the Supreme Court now to reconsider any verdict that we have in the past considered to be, established law, and what will they do next, especially, if they gain, even more control. So I'm in just a terrible mood over the whole thing, but your presentation was really helpful and fascinating.
Thanks. Yeah, I would just say, I'm not a legal scholar, I'm not a political scientist, but I think that's an important and interesting, separate conversation about how the Supreme Court functions or doesn't, and what's happening with that, and the issue of the legitimacy of the Supreme Court being challenged by some people. And I think those are the kinds of conversations that I wish more Americans were having with each other. And unfortunately, I think because of the way that US politics have gone in the last, 6-8 years, people have not wanted to have controversial conversations with each other anymore, right? It feels too confrontational, it feels too divisive. And so people are avoiding really important conversations. So I'm glad you brought it up. I think people should be talking about it more.
So I just want for you to talk a little bit about the conversation surrounding abortion, particularly in the political context in recent months, and juxtapose that with the conversation around, say, masking, some of the decisions that were made during the COVID pandemic or the pandemic that we're still in, and just sort of the language and the tenor used by politicians, everyday citizens, et cetera.
Yeah. Yeah, I mean, I think that just segues from my talk about things being, or my comment about things being so divisive and feeling so confrontational, right? It's like with masking, with vaccinating, people were very divided from my experiences and knowledge, right? You were either strongly for it or strongly against it. There weren't a lot of people in the middle. And I think that that is how people tend to feel about abortion. And I think that one of the benefits of the work that my group did in Ohio is to show that it's a lot more nuanced. Abortion issues are really nuanced. And the things that we see in the media are usually outrageous examples, right? Like the examples that I used in this presentation about people not getting access to their medications or having to carry a dead fetus for 2 weeks, those are extreme examples, but it's important to know those examples, and it's also important to understand all the nuance in between, I think. So I don't know if that answers your question or addresses it, but I can see how they're kind of being handled parallelly. Okay.
Earlier you said you didn't have an opinion on abortion. I'm just wondering why that is. Or
No,
I'm
I
curious.
have an opinion on abortion, but it's pretty broad, and I don't pick apart each law and form an opinion on each law, because honestly, it would be emotionally draining and time consuming, and the laws are constantly changing, and I just don't.
What do you think about the issue that I feel like we're heading in the direction of where people who are pregnant, or even just people who have the ability to become pregnant, would be denied transportation across state lines because they might be seeking abortions?
Yeah, so I think there's a lot of kind of fear mongering happening right now too. And I don't know how people would be like universally denied transportation across state lines. I think it could be harder. It's already hard for some people to get any sort of transportation, right? There are lots of people who don't have their own cars, and they can't afford the kind of transportation that they would need to go 2 hours, 3 hours, wherever it is to get access. So I think also going back to Desmond's question, the issue of abortion access, because people feel so strongly about it, typically in one direction or the other, is resulting in a lot of kind of conspiracy theories and just like jumping to conclusions and worst case scenarios. And so I think it's something to keep on the radar, but I don't know if I'm really answering your question, but.
Meredith, is there one more question in the chat?
Yes. I really struggle. I've lost my mouse again. Oh, here it is. Oh, wait. Okay. Karen Porter says, are you finding that your students are moved by what's happening around abortion right now? Do you sense an urgency on the part of young people to fight to safeguard abortion rights, given the Dobbs decision? I would say yes, personally. I've had lots of students who I hear them talking about the abortion issue and upset about the Dobbs decision. I have had some students articulate excitement to know that I would be teaching about or talking about abortion. So it definitely seems to be on students' minds. I don't know if there are students in the room. They might want to say whether they're interested in it. I think they are if they're here, but yeah. So it's definitely something that people, especially young people, are thinking about and concerned about.
Okay, well, I'd like to thank Meredith again for a very informative presentation. And if you've got more questions for Meredith, please come to the front and talk with her. And see you next week.